Hi, ACR 2020. This is Dr. Robert Chao coming to you live from Room Now. I'm joined today by Dr. Monica Guma. I'd like to first start off by letting you introduce yourself, Dr. Guma.
Hi, Robert. I'm Monica Guma, and I'm a rheumatologist at UCSD, and I'm doing research in rheumatoid arthritis and diet.
Great. Yeah, so the reason why we have you on today is I saw you had a very interesting talk on the trial of diet to impact rheumatoid arthritis and gut microbiome. So obviously a lot of questions. I'm gonna start off with the most important question. What should we be eating and what should my patients be eating? And please tell me it's more hamburgers.
They are not hamburgers, I'm sorry. No hamburgers in the diet. I think that there are like a lot of data already, and actually a lot of websites, even some rheumatology good websites, that they also have ideas and advices for the patient. So it's true that we sometimes don't know how to answer that question, but if you Google, you go to these foundations, they already give a lot of information, and we know what kind of diet they need to eat. There is a more classical Mediterranean kind of diet, or more like a plant-based diet, as we know, and there are some data about that. I think that the only difference now is that we can really focus more on the mechanism. But the advice to the patients, I think, is easy to give this kind of advice, and not hamburgers, not red meat. That's for sure. The first thing you have to forbid actually is the red meat. Yeah.
I can say I tried and asked when my patients ask me. So I went through the study and I saw your diet. The one that you tested on, I think it's feasible. Did you find any issues with adherence, especially long-term adherence?
Mm-hmm. So the trial that we will present in our presentation tomorrow, it was really like a pilot trial. So we actually wanted to see if the patients, they were more also adherent to the whole trial itself, because we wanted stool samples, blood samples, so that sometimes is difficult. So the trial was only between 2-3 weeks, so it was a short trial. And we have no problems for adherence in this short-term trial. When we build the diet, we build the diet with the feedback, helping feedback from other patients. So we already kind of put the right schedule, right kind of instructions to help a higher number of patients to be able to follow the diet. So I think this diet is really feasible and is easy to be adherent. What I think is difficult at long term is not to take the things that they are forbidden. So for our patients, it was easy for them for 2 or 3 weeks to stop drinking soda or to stop eating hamburgers, okay? But if you want to do a long-term diet, some of these things you need to be more flexible, because there is no way a real patient will be able to follow so strict and so kind of like the diet. But that's okay, because if you change 80% of your diet, is of course much better than 0%, So right. Even if you once in a while you are going to do a transgression, and probably you will feel that day maybe some pain or some swelling, it's normal. It's our own decision to say okay, but the rest of the time you are eating different, and you are changing these we don't know if microbiome or metabolites or both, that helps the inflammation.
Got it.
That's the goal.
And, yeah. Well, since you mentioned, it was a 2 to 3 week study. As far as the results, I think I saw very interesting results. Would you comment on that? And do you think it was surprising to you, or was this what you expected?
So the thing that it was surprising to me was actually the fatigue. So we were, so the patients, when we saw them 2 or 3 weeks later, but we gave them the questionnaires, so they could really give some feedback in between. So then at the end of the trial, after the 3 weeks, when they came back to our clinics, we collected the questionnaires and we asked them their feedback. And one of the most important things, or things that we didn't expect, is that very, very, very shortly, maybe in 3, 4, 5 days, they noticed a decrease of the fatigue and increase of the energy and feeling better overall. It doesn't mean that was specifically the joints. I'm talking about general improvement, okay? That was quite homogeneous. Then another thing that it was also interesting is that, of course, we don't have placebo, so it's very limited, no, how we interpret the results. But it was obvious that some patients, the improvement was really striking, like a really swelling when gone, literally gone. Okay, and other patients that they didn't respond so well. And in the analysis, that we cannot blame that to the adherence, because most of them, the adherence was quite okay. So we have to think that, or to interpret that is something intrinsic, that even if changing the diet in the same way, not everybody was responding the same. So again, short term, we don't know if the patients that didn't respond, they would respond in a longer trial, okay? Or the ones that they responded, it was only like a short term, who knows, maybe then at the end. So that's why we are now doing a longer trial. But that was the feedback that we were getting from the patients. Overall, very good in terms of like a fatigue, energy, like a well-being. But then when we went specifically with the joint and swollen, tender joints, swollen joints, the result was like a 50-50 of like a super good response, or only very like a moderate or no response. Yeah.
So, I still think it's very surprising to even see a 50-50 swollen joint count improvement in 3 weeks with diet change. Do you have any information on were these diet changes from someone, let's say, who was on a very bad diet, or were they already quote unquote on a healthy diet and now they're on a healthier diet?
So we know that the patients that they did respond better, they were already on a healthier diet. That we know. That's why we think that maybe some patients, they need more time to respond. So patients that they were already taking, eating a lot of like vegetables, and they were like overall having what we name, no, like a diet score, because we had to score the diet somehow, no. So they were already on a better diet score, they responded better. That's what we know. Okay. Then the adherence after all was very similar. But going back to what you said about is surprising not to respond too quick. And that again is because it's short term, so that you have to be limited. You know that our patients, when sometimes they come to our clinics and you ask, how have you been doing in the last 3 months? They say overall well, but they had a couple of weeks that I felt really bad. So it's true that sometimes the disease has some flares, that it can be environmental and we don't know, and that they get very, very well controlled. So I think that some of these things that people don't realize, or they do sometimes, they tell me, I had a bad week, but that week I was traveling and I was eating a lot of like junk food. They realize, they don't know the ingredients, and they realize. So I think that you can actually like you can potentially be taking something that you don't know, that is actually inflammatory in your diet, that you don't know, and then you remove that thing and you feel better. So the thing is probably that thing is not the same for all the patients. That's why you have to change the diet overall. But maybe that patient is only the gluten, you know what I mean? Or maybe it's only the milk. That's the next step, to try to be more personalized. Right. But yes, I think that's the situation. That's why they do respond. Yeah.
Right. And I think the second part of your study that was very interesting commented on the gut microbiome. I think that's a big topic again this year. And I think, also many ACRs in the past. Can you comment on what you found as far as gut microbiome, the diet, and of course, in relation with our diseases?
Mm-hmm. So we know that that the microbiome, there is a dysbiosis in arthritis. We don't know if that's the cause of the consequence. So that's very important. We know there is a lot of data, but we still know very little. Okay, because it's very different if that's a consequence of being sick. And of course, you will have changes, and they are not related to the disease, or really these are the cause. Okay, so more data about that are needed. But in terms of like a diet, it's already known that diet is not the most important like a factor that changes the microbiome, especially in an adult person. So an adult person has a history of tons of factors that is actually shaping the microbiome. And the microbiome is quite robust. So maybe you can shift the microbiome a little bit, but it will go back to what it was before. So the microbiome overall, we didn't see big changes. What we are analyzing in detail now is maybe as a specific bacteria maybe that is the one that you are changing. So we were not detecting big changes. There is a lot of like ways to interpret the microbiome. Is called, it's kind of like a diversity. Okay, how diverse is your microbiome? We didn't see much changes on that. We saw that the patients that they did respond, they have like a better, larger diversity that correlates sometimes with healthier diet. Okay, but it didn't change much. But we are now seeing if some specific microbe actually was changing, and that maybe it can be causal and not consequence. We still don't know. Okay, so that thing. On the other hand, what we are, and I'm not really an expert on microbiome. I analyze microbiome because it's a way to interpret the metabolites. That is what I'm very interested. So circulating metabolites makes sense that they can be also pro or anti-inflammatories, and that is the like the product between diet and microbiome. So maybe the microbiome doesn't change much, but because you're changing the diet, you are changing the final product. Is all the metabolites, the circulating metabolites, that probably 70%, they depend on the diet. So those metabolites are the ones that we are analyzing in detail to see if some of them are actually correlated strongly with improving after diet. That would be a little bit the conclusions, no, of our like trial. Again, limited for the time and the design, but that's how we are building the next trial to try to answer these questions.
Great. Well, thank you so much for your input, and you're explaining for everything to us in detail. Definitely a very fascinating topic. We look forward to your upcoming trials and the longer studies. From Room Now, this is Dr. Robert Chao and Dr. Monica Guma. Thank you for tuning in, and for full coverage, continue to follow Room Now and follow me on Twitter at Dr. RBC. Thank you.
Thank you.